Hi, my name's Joanna Baker, and today we're going to talk about what to do and what to consider when the low FODMAP diet doesn't work. So the research tells us that around about 50% to 80% of people who have got IBS type symptoms will get a significant and consistent improvement with a low FODMAP diet. What that means is that it doesn't actually work for everybody, and we're left with around about 20 to 50% of people with these symptoms who are not getting results and are left feeling confused and frustrated about what's going on. So before we jump into things, I'll tell you a little bit about myself. My name's Joanna Baker. I'm an accredited practicing dietitian and I'm also a registered nurse. I'm the owner and founder of Everyday Nutrition. At Everyday Nutrition, we are gut health specialist dietitians. We're all FODMAP trained and we all specialise in intolerances beyond low FODMAP as well. So we love to work with people one-on-one here in Melbourne and also virtually via telehealth. And we like to help people who've got digestive issues really pinpoint their triggers so they know what they can eat and what they need to limit so that they can really start enjoying food and getting back to enjoying life and kind of take control back so that they're in control of their gut instead of their gut being in control of them. I myself have had IBS symptoms for the majority of my life, and I really don't remember a time when I haven't been managing things to a certain degree. What this has done is it's taught me how debilitating it can be to be living with unpredictable symptoms and how much they have an impact on your daily, day-to-day life. But it's also taught me how good it can feel and how exciting it is when these things are really well managed. That's made me really passionate about working in this area and working with people to achieve this as well. Over the years, I've written for FODMAP magazine, I've written for Australian Gluten-Free Life magazine, I've written also for Healthy Food Guide, and I've also presented on FODMAPs to the general public. So I have been involved in the Free From Show in 2019 and the virtual Free From Show in 2020 and again this year. I've also taught FODMAPs in Melbourne, Sydney and Brisbane and also overseas in Chicago and Dallas. I'm currently on the advisory board for the Master of Dietetics program at Deakin University here in Melbourne. I am a committee member of the Food Allergy and Intolerance Interest Group with Dietitians Australia. And I also do a little bit of work in the food industry. So in the past, I've worked for FODMAP Friendly and FODMAP Testing. I've done work with FODMAP for You. And I'm also currently involved with a low FODMAP certified fibre supplement called K-Fibre. Let me start by introducing you to Lisa. Lisa, not her real name, I've changed it for privacy purposes. But Lisa came to see me, this is way back in about 2018 now. And when she came to see me, she was experiencing symptoms of daily bloating and a type of burning in her digestive tract. She was getting sporadic good days, but they were few and far between. And the majority of the time, she was rating her symptoms at around about 7 out of 10 in severity, with 10 being the worst ever and 0 being nothing at all. In addition to this, she was experiencing constipation. She was having a bowel movement probably twice a week. It was usually small, it was hard and difficult to pass, and she often needed Movicol to get things moving. One thing that she had noticed that was interesting is that she also suffered with skin rashes and eczema. And this seemed to be particularly bad on the same days that her gut symptoms were particularly bad, which was starting to lead her to believe that food was related to triggering these skin symptoms as well. In terms of her medical history, Lisa's fit and healthy. She's seen her GP, she's seen a gastroenterologist, and they couldn't find any physical reason for the symptoms that she was experiencing. And she had also been tested for celiac disease and was gene negative for celiac disease. She takes psyllium and Movicol as directed by her GP to help keep those bowels moving. Lisa had been following a low FODMAP diet for about 2 years now, and over that time she had around about a 50% improvement in her symptoms, but she was still getting unexplained flares of symptoms and a lot of inconsistencies. And when she was looking back through her food diary, she wasn't identifying any high FODMAP foods that could explain these flares, but she'd noticed a little bit of a pattern where there were certain foods that were supposed to be low FODMAP, but they seemed to be triggering her symptoms a lot of the time. She also has a family history where her father and her grandmother also had IBS type symptoms as well. So just a little bit about irritable bowel syndrome. So IBS is what we call a functional condition. And what this means is that there is nothing physically wrong with the body, that a person is experiencing abdominal symptoms like bloating, pain, wind, constipation, diarrhea, or alternating between the two without any medical reason that these could be happening. It's actually that the prevalence, so around the world, around about 1 in 7 people are experiencing IBS type symptoms, so that's about 15% of the population, which makes it pretty common. It's the second most common reason that people are taking time off work. It's the most common thing that's diagnosed by a gastroenterologist. The most common age for diagnosis is those childbearing years, and we know that 2 out of 3 people with IBS are female, and they are being diagnosed generally between the ages of 25 to 45 years. Although IBS impacts significantly on work life, social life, intimate life, so your daily ins and outs, whatever you're doing, 70% of people with IBS still do not seek medical advice. Because IBS is functional and we don't have a cause of IBS, it also means that we don't have a cure for IBS. This can be really frustrating. So people are seeing their doctors, they're being tested, and the GP is sitting there saying, I can't find anything wrong with you. The person is sitting there saying, well, why am I experiencing all these symptoms yet? There's something wrong with me, what's going on? And both parties are getting quite frustrated by this as well, because the doctor wants their patients to feel better, and the person wants to feel better, but they don't know what to do about it. Our goal of managing IBS is really to improve those symptoms, and by improving those symptoms, we really improve that quality of life. Interestingly, around about 95% of people who have IBS identify diet as a key factor in making their symptoms, or triggering their symptoms, or making their symptoms worse. So when we're diagnosing IBS can actually have almost identical symptoms to some other more serious medical conditions. And so when somebody's coming along to their doctor with these abdominal symptoms, we really want to make sure that there's nothing medical going on there. So the doctor will usually do a blood test for celiac disease, and I will note that celiac disease blood test, you do need to be eating gluten for this to be accurate. If you're already on a gluten-free diet, that test will be negative regardless of whether you have celiac disease or not. And the doctor will also screen for any of what we call red flag symptoms, which could indicate that there is something else going on, something like IBD, like Crohn's, colitis, or even bowel cancers. So those are things like unintended weight loss, family history of bowel disorders, any rectal bleeding, unexplained iron deficiency, anemia, nocturnal diarrhea. And we usually put age over 50 as that red flag symptom there as well, because if somebody is over 50 years of age, we really do need to be investigating and doing stool tests and colonoscopies and gastroscopies before we can diagnose them comfortably with IBS. If somebody has had all of those medical tests and been seen by their doctor or a gastroenterologist, and they cannot find any medical reason for these symptoms that are occurring, the next thing we do then is we compare their symptoms to what we call the Rome 4 criteria. And the Rome 4 criteria is used to officially diagnose somebody with IBS. And that states that a person must have had abdominal pain, and it must have been on average at least 1 day per week, and it must have been ongoing for some time, so around about 3 to 6 months. It's not a one-off thing that's happened. It's chronic, it's ongoing. And that pain has to be associated with 2 out of 3 criteria. So it needs to be either related to having a bowel movement. The second one is that it's possibly related to a change in frequency of bowel movements. So you might be going more often or less often than might be considered normal. So in Lisa's case, she's going around about twice a week, which is less often than what would be considered normal. Or it also might be associated with a change in what the stool looks like, so its appearance. So it might be loose or watery, or it might be like little sheep pellets. So if you're familiar with the Bristol stool chart, either end of the stool chart rather than that nice normal sausage that we expect to see in the middle. So once somebody has been diagnosed with IBS, The next thing to consider are what are the contributing factors, and we know that irritable bowel syndrome is what we call multifactorial, which means that there are lots of things that can contribute either to triggering or exacerbating these abdominal symptoms. So obviously we've got our food triggers, so we know all about we've all heard of the low FODMAP diet. That is one possibility that does contribute to IBS symptoms. We know that hormones play a role, we know medications play a role, we know eating behaviours, things like meal size, meal spacing, those sorts of things can play a role. Gut irritants, here I'm talking about things like spicy foods, alcohol, caffeine, which can all irritate the gut. Pelvic muscle function, so that muscle function on that pelvic floor can have quite a significant impact on how easy it is to empty the bowels, which can then lead to ongoing abdominal symptoms, and also that gut-brain axis. And the gut-brain axis, I'm talking about the sensitivity of the nerve endings in the gut, and I'm talking about that communication up the vagus nerve between the gut and the brain. Now, because IBS is multifactorial, it also means that treating IBS becomes what we call multimodal. And I certainly find in my experience is that the people that I work with who've got what I like to call an IBS toolbox, and in their toolbox they've got lifestyle and psychological things. So they're doing things like looking after their mental health, making sure they're getting enough sleep, they're getting enough to drink, they're getting enough exercise during the day. Also in their toolbox they might have things like supplements, so they may have fibre supplements, they may have medications, they may have things to help with bloating and gas and those sorts of things. And then on top of that, also in their IBS toolbox is their diet and their eating behaviours. So that might be things like moderating their trigger foods, making sure that they're getting regular spaced meals. We know that the body really likes routine, and making sure that they're keeping some sort of routine with that, not overeating, not undereating, those sorts of things. And absolutely the people who look at all of these factors, these are the ones that get far superior results than people who just look at one thing on its own. So as a dietitian, really my area of expertise and what is really the nuts and bolts of what I'm doing with people is working out what's going on with their food triggers. And when I'm looking at IBS, there are actually lots of different things that can be involved in triggering symptoms. So obviously we've got a FODMAP diet, which is extremely well known these days. And I feel like, and maybe I'm biased, but I feel like every man and his dog who's ever had a stomachache has tried a FODMAP diet at some point. We've also got what we call food chemical sensitivities. We've also got whole food sensitivities. There is Sucrose-isomaltose intolerance, SIBO or small intestinal bacterial overgrowth, bile acid diarrhea, gut irritants, and absolutely the longer that I'm in this game, the more I realise we just don't know. Science does not understand yet about food intolerances. So I'm always going to put at the end there food triggers that are not yet evidenced. Now, identifying food triggers for IBS can be really quite a tricky situation. We tend to put multiple foods together to make up a meal. And usually when we're looking at abdominal symptoms related to a food trigger, we're talking about symptoms occurring anything from 6, 8, 12, 24, even 48 hours after eating the food. So if you're trying to think back over the last 24 or 48 hours of all the different foods that you've eaten, any one of these could be a possible trigger. So that makes identifying triggers really quite difficult. As a dietitian, when somebody is coming to see me with these triggers, with these symptoms, the first thing I'm going to be doing is I'm going to be screening them. I'm going to be wanting to know what their symptoms are, what their symptom history is, what they've tried to manage their symptoms, what's worked and what hasn't worked. I want to know about their medical history. I want to know if they're taking medications, what testing they've had done. I want to know what they're eating, and I want to know what foods they are suspicious of as well. And what I'm really looking for here is any patterns that are occurring between the types of symptoms they're getting. So what sorts of sensitivities do their symptoms correlate with? So with Lisa, we're looking at skin symptoms and abdominal symptoms. I'm also looking at what are they eating a lot of. So if they're already eating a low FODMAP diet and they're getting symptoms, but they're not eating any FODMAPs, then I can almost say, okay, so there is something going on that is not FODMAP related with this person, because they're not eating any FODMAPs that could explain why they're getting the symptoms. I also want to see any patterns between what they're eating and what they think their trigger foods are. So have they identified a whole lot of trigger foods that fit into one specific category and no trigger foods that fall into another specific category, or where are these categories crossing over? And once I've identified that pattern, what I'm going to be suggesting more often than not is some sort of elimination diet. Sometimes it's a low FODMAP diet, sometimes it might be a food chemical sensitivity, sometimes I might tweak specific things, so I might remove gluten or dairy or soy or something like that. And that essentially is a trial that lasts usually around 4 to 6 weeks. And what I want to know from this trial is, does removing this group of molecules or these specific foods, does that make a difference to their symptoms? If it does make a difference to their symptoms, then I know that we're on the right track. But at this point, we still don't know for sure if we are what the trigger is, because just removing something from your diet and getting better does not guarantee us that that is the trigger. And I've absolutely, both myself and with other people as well, I've seen people remove things like gluten or dairy, and then when we reintroduce it into the diet, we find that it's really well tolerated and it's not the reason for the symptoms, even though they felt better by removing that food. So that next step then is to move on to that challenge process. And this challenge process, this is probably the part to get the most well structured and the most methodical, because we really want to use specific foods that really isolate specific molecules, and we want to reintroduce that in a really structured way so that we can see, does reintroducing this molecule actually make this person's symptoms worse, or does it not make those symptoms worse? Because it's that ability to trigger symptoms is when we can be absolutely confident that this food is a trigger food for that person, and triggering symptoms in a structured way. Once we then know what a person's triggers are, we then move to that next step where we want to liberalize the diet as much as possible, because we want people to have as much variety as possible. But at the same time, we want to keep those symptoms minimal. Ongoing, we do know that intolerances and thresholds can change during somebody's lifespan. So just because you're particularly sensitive to a specific thing this year, that doesn't mean that life won't change next year, that something else might be happening in your life, and your tolerance to that food may improve or it may decrease. So I'm always encouraging people to go back every 6 to 12 months, see, can we push these boundaries just a little bit? The other thing that I've also seen is that sometimes we find that if we've got a food that is triggering, say, constipation, for example, and we remove that food and we haven't got the constipation anymore and the bowels are moving quite freely, sometimes if things are moving that little bit too freely, by bringing that trigger food back that triggers that constipation, sometimes we find that nice balance between keeping things nice and formed and not too fast and not too slow. So sometimes including small amounts of trigger foods can actually, for the result that they provide, can actually be a part of that picture as well. So keeping in mind that these trigger foods, they do not damage the body, they do not shorten lifespan, they do not cause an antibody release. So it's 100% about managing symptoms with these people and tweaking the diet to get it right, to get the result right. And sometimes that does mean including small amounts of trigger foods very, very carefully and in specific times. FODMAPs. FODMAPs, these are types of carbohydrate molecules that do not get absorbed properly in the body. They go in one end, they travel through the digestive tract, they come out the other end when you have your bowel movement. As they are passing through the intestines, there are two things that FODMAPs do that we know trigger symptoms in people who have got more sensitive gut. The first thing they do is that FODMAPs are sucrose-osmotic. So when they are traveling through the intestines, right down the end there, FODMAPs attract water into the intestines. And if we fill those intestines with water, you're going to feel full, you're going to feel bloated, and all that water has to come out somewhere, and that's going to cause loose or watery bowel movements. The other thing that FODMAPs do is in that large intestine or that colon, that's where your gut microbiome is. And your gut microbiome contains around about 2 kilos of live healthy bacteria that do good things for us. But as the bacteria are alive, they actually need a fuel source to stay alive and to stay healthy. And there's nothing they like more than feeding on FODMAPs. So when the FODMAPs are passing through that large intestine there, The bacteria that live there, they're feeding on those FODMAPs, and when they feed, they create gas as a side effect. That gas is swelling in the intestines, it's making people feel bloated, it's making them windy, and it's also stretching the walls of the intestines and pushing on those nerve endings that are in and around the abdomen. And it's that pressure on those nerve endings that's making people super, super uncomfortable from FODMAPs. FODMAPs are found in a variety of foods. FODMAP is actually an acronym. The F stands for fermentable because these are carbohydrates that are fermented in the large intestine. The O is the oligosaccharides, so the fructans or fructooligosaccharides and galactans or GOS. And these are found in foods like wheat, barley, rye, onions, most legumes, artichokes, chicory root and watermelon all contain oligosaccharides. The D stands for disaccharide, which is lactose, lactose being the disaccharide that we're interested in terms of FODMAPs, and lactose is found in things like milk, yogurt, ice cream, custard, those sorts of foods. I will note that hard cheeses and butter are not considered high FODMAP because they're low enough in lactose that we don't need to worry about the lactose, the trace amounts of lactose that may be found in them. The M stands for monosaccharide, and the monosaccharide we're interested in here is fructose, and we're looking at fructose in its relationship to glucose. So glucose really aids in the digestion of fructose. So if we've got foods that have got equal amounts of fructose and glucose, then they're actually low FODMAP. What we care about is if a food has got more fructose and less glucose, and it's that excess fructose there above the glucose, that's the part that's high FODMAP. And we see excess fructose in foods like honey, mango, watermelon, apples and pears, and of course your high fructose corn syrups. The A is the easiest FODMAP to remember, that's and P stands for polyols, which is sorbitol and mannitol. These are sugar alcohols. They're not like the alcohol that you drink. It's about the biochemical structure of the sugar molecule, and we see polyols in apples and pears and stone fruits and mushrooms, cauliflowers, and we also see them in things like artificial sweeteners, like sugar-free gums, and sometimes we see them in protein bars and low-carb bars and things like that as well. So moving on to naturally occurring food chemicals. So when I'm talking about these, I'm talking about chemicals that occur naturally in our food supply. So these are not always things that are artificially added. And there are actually 4 types of food chemicals that fall under this umbrella. So we have salicylates, we have amines, we have glutamates, and then the 4th type is where we have the additives and preservatives. So it crosses over. There are some natural, and then there are some that may be artificially added. Food chemicals are a little bit different to FODMAPs. We all eat them because they occur widely in our food supply, and when we eat them, they go down into the stomach and into the small intestine, and then they get absorbed into the bloodstream along with the other vitamins and minerals and carbs and proteins and foods that you're eating. Food chemicals can also enter the bloodstream through inhalation through the lungs, in the same way that the medication in your asthma puffer will enter your bloodstream through the lungs as well. The thing is, we all eat these, and our body, they're not dangerous, and when we eat them, they occur in the bloodstream. They'll be metabolized and they'll be flushed out of your body in the way that the body is designed to work. But if you're somebody who is more sensitive to these food chemicals, it's likely that you'll have a threshold. And when you go over this threshold, they tend to cause a generalized irritation of nerve endings or a histamine type of response that is involved in triggering those types of symptoms that we see from food chemical sensitivities. Most of the research into food chemical sensitivities is done by Royal Prince Alfred Hospital, the allergy unit up there in Sydney. Food chemicals are found in quite a variety of foods. Salicylates are actually a plant chemical. They're a natural antibacterial that plants produce to protect themselves out there in nature. And they're actually designed to make living beings feel sick or unwell. So when a plant is sitting out there in the world all on its own and it's growing its fruit, so say it's growing a nice juicy red apple, inside that apple is the plant seed, and that's hopefully going to fall off the tree eventually and then grow another plant. And so the tree actually wants to protect that apple. So it produces salicylates. That puts the salicylates into the skins of the apples. If we're talking about things like spinach and silverbeet and those leafy things, it'll put the salicylates all through those leaves. And when a bug comes along and takes a bite of the apple or of the leaves of the spinach or whatever, then the salicylate in the food will make the bug feel sick or unwell, and it will leave the plant alone. We know that some people are more susceptible to salicylates than other people as well. Because they're a plant chemical. We see them in fruits and vegetables. We see them in tea, coffee, herbs, spices, honey, fruit juices, of course, beer, which comes from hops, barley, wine. We see salicylates in mint toothpaste. So herbs in particular are particularly high in salicylates, and that mint toothpaste is enough to trigger a response. And aspirin itself is made from salicylic acid. Amines are a little bit different. Amines are a product of protein breakdown. So as fruits and vegetables age, as meat ages, or as cheeses age, the proteins break down and they start to release amines. And what the amines do is they actually increase the flavour, and they soften the texture, and they increase the aroma of the food and make it taste good. So they make it rich and flavoursome. We see amines in things like overripe bananas, overripe avocados, overripe tomatoes. We see them in aged meat. So if a steakhouse is aging its steak for 21 days, it does that to increase the flavour and the texture of the steak, which is what the amines actually do. So it will age a steak to increase the amines purposely. We see amines in soft ripened cheeses like bries and blues and camemberts. Chocolate contains quite a lot of amines, and also things like fermented products, things like sauerkrauts and pickles, and those sorts of foods that tend to be fairly high in amines as well. Glutamates are not too different to amines, so these again are natural flavour enhancers. We see glutamates out in nature. We don't see glutamates on their own. They're always with amines. We see amines alone, but we don't see glutamates alone. So we see glutamates in a lot of cheeses, tomatoes, mushrooms, eggplants, avocados, and those sorts of foods. And glutamates are the one that actually crosses over. So they occur naturally, but MSG is also a glutamate, and that has been isolated as a flavour enhancer, and that is often used in food processing and a lot of those savoury snacks to enhance the flavours. Other additives and preservatives we see are things like sorbates, benzoates, propionates, nitrates, antioxidants, and artificial colours as well, all fall under this food chemical umbrella. Now, remembering that food chemicals, when we eat them, we absorb them into our bloodstream, and when they go over that threshold, they cause a histamine type of irritation of nerve endings response. What that means, because they're in your bloodstream, we actually see a lot more systemic symptoms with food chemicals. The symptoms, they can vary from person to person, and they can affect just one body part, or they can affect multiple body parts. We tend to see things, so if they're irritating the gut, we see IBS type symptoms. Neurologically, sometimes we might see headaches or migraines or extreme tiredness, or I have people that talk about having a type of hangover type feeling where they're just exhausted and they feel that brain fog coming on. We can see sinus and respiratory tract type things like sinus congestion, asthma, throat irritation. Some people have a chronic cough a lot of the time. And obviously we also see skin reactions, things like hives and swelling and eczema as well from food chemical sensitivities. So when we're comparing FODMAPs and food chemicals, it's quite interesting because there is a little bit of a crossover between the two, where there are some foods that are high in both FODMAPs and food chemicals, but there's also some differences as well. So if you've got somebody who is food chemical sensitive that goes on a FODMAP diet, they potentially may lower their food chemical load a little bit because they're going to stop eating things like onion and cauliflower and avocado and honey and sauerkraut, and those are all high in food chemicals and high in FODMAP. So they may see an improvement because they've lowered their food chemical load. On the other hand, what we tend to see then is that they get an improvement initially, and then they start playing around. They get a little bit bored with their diet, and they start playing around with adding some more low FODMAP foods in to make food that little bit more interesting again. And that's often when we start seeing some of these symptoms come back again, because they start eating more strawberries and capsicum, and or they might be eating more bries or camemberts because those are all low FODMAP. And then those symptoms start to become that little bit inconsistent. Now, symptom-wise, when we're comparing the two, both FODMAPs and food chemicals are related to threshold and related to dose. So small amounts are usually okay. When we're starting to get to larger amounts, that's when they start to become problematic. Neither of them will damage the body, but both of them do cause quite debilitating symptoms. FODMAPs, we don't see withdrawal symptoms with FODMAPs. However, we've all heard about people who drink a lot of coffee and they suddenly stop drinking coffee and they get withdrawal symptoms from stopping that caffeine. We also see this phenomenon in food chemical sensitivities, where if somebody does lower their food chemical load, when they're sensitive to those food chemicals, we'll often see those withdrawal symptoms from lowering that load of food chemicals. Usually that happens within about the first 2 weeks, where people will get better and then they'll get worse and then they'll get better again. When it comes to perfumes and soaps, we don't worry about these at all with FODMAPs, but with a food chemical elimination diet, we do switch to perfume-free products, at least during that elimination phase. Both cause gut symptoms. Food chemicals cause skin symptoms, while FODMAPs do not cause skin symptoms, because remember, FODMAPs do not get absorbed into the bloodstream or the body, so there's no way they can get from the gut to the skin. Whereas food chemicals are in the bloodstream, so they can access those nerve endings around the skin. Neurological symptoms, so central nervous system. Obviously, if somebody is living with, is sensitive to FODMAPs and is living with those gut symptoms, we do see anxiety and things, and depression are fairly highly correlated with that. And look, living with those gut symptoms, that makes anyone feel miserable. But when it comes to food chemicals themselves, is that we know that food chemicals themselves can actually trigger that irritability, those mood changes, fatigues and headaches and things. And I actually have seen children in the past who we specifically use this diet to manage behavioural issues in children, and it's almost like a light switch where we can turn their behaviour on and off literally by introducing some of their trigger foods or removing some of those trigger foods. FODMAPs don't cause sinus problems or airway symptoms, whereas food chemicals do cause sinuses and asthma. And when we're talking about how soon those symptoms occur with FODMAPs, remember, food's got to travel through the esophagus, through the stomach, through the small intestine, and the FODMAP symptoms are occurring when the FODMAPs are in that large intestine at the very end of the digestive tract. We're looking at a window of around about 4 hours after eating the food, up to 24 hours. With food chemicals, symptoms can occur sooner. So I've seen people with as little as 30 minutes to an hour after eating a food, they might start feeling those symptoms. And even some people, I have had people that when they're actually eating the food, they're already getting a tingling in their mouth from that trigger food they're eating. The other thing with food chemicals, they're in your bloodstream, so they can build up over days. With little bits every day, they can build up over several days. So that window is much, much wider with food chemicals. So the next thing I want to talk about a little bit is what we call Sucrose-isomaltose deficiency. And this is when somebody has got a deficiency of a specific enzyme that's involved in breaking down the sucrose so that it can be absorbed. If somebody is low in that enzyme or doesn't have that enzyme, we do get undigested sugars in the digestive tract going through into the colon, where we might see similar sorts of symptoms to FODMAPs. This is most commonly diagnosed in children, and there are actually two types of sucrose-isomaltose deficiency. We have primary, which is a genetic variant where people will be born without the ability to digest these sugars. We also have secondary sucrose-isomaltose deficiency, and this is where enzyme may be low as the result of another condition. So if somebody has celiac disease that is untreated, that's caused damage to the lining of the gut, we might see a temporary sucrose-isomaltose deficiency, and then once they're on a gluten-free diet and the gut grows back and becomes healthy again, then the sucrose-isomaltose deficiency may go away. The types of symptoms that we see are very, very common to IBS. So we see pain, we see bloating, we see diarrhea. In children, we sometimes see malnutrition or failure to thrive, where they're not growing and they're not meeting those milestones. Diagnosis, that's done through a gastroscopy and a biopsy from the small intestine, which is then looked at under a microscope to confirm whether the specific enzyme we're interested in is there or not. There's also breath tests that we can do, and there's also genetic testing that can be done for this as well. When we're looking at treatment, it's generally a low sugar, low starch diet to get those symptoms to resolve, and then a gradual reintroduction of those foods to sort of find out where that threshold is, how much is okay, how much is too much. There is an enzyme that can help with this, but the enzyme is not widely available, and particularly here in Australia, we've had a lot of trouble getting it. But overseas in the US, you can often access an enzyme called Sucrose that helps with this as well. Which brings me on to whole food intolerances. Now, this is one where there is really a very unclear mechanism of action. We don't really know what's going on with this, and these are not well researched. It may be related to intestinal permeability, it may be related to gut microbiota changes, there may be some immune activation going on. The most common foods we see this with, in my experience, are wheat, dairy, soy, and eggs seem to be some of the most common foods where people just won't tolerate amounts. Sometimes it's certain amounts of these foods, sometimes it's even small amounts of these foods. And they do get symptoms, gastrointestinal symptoms, so they might get bloating, pain, altered bowel movements. I do see people who wheat might trigger skin reactions or sinus symptoms. Sinus in particular is fairly common with milk protein, so we might see that phlegmy type of congestion sort of thing when people have large amounts of milk, and sometimes we might see neurological symptoms as well. In terms of diagnosing these, of course, the first step is to exclude any medical conditions. So if someone's sensitive to wheat, we want to know, is it celiac disease or is it not celiac disease? Because if it's celiac disease, our goal of treatment is different to if it's a wheat intolerance. So we really want to know what we're dealing with, because once we know what we're dealing with, that's really going to guide our management of it, which is generally done through dietary changes. So it's an elimination followed by that food reintroduction to find out where that threshold is. So SIBO, small intestinal bacterial overgrowth. We see a lot of this on the internet, and what it actually is when the bacteria or the microbiota that are supposed to be living in that large intestine start moving backwards and crawling up the digestive tract and start living in that small intestine. SIBO is not well understood. It's difficult to diagnose. So that usually when we're doing our diagnosis, there's breath tests that we can use to diagnose SIBO, or we can be using things like a jejunal aspirate. The breath test, look, it's not invasive, it's easy to do, but breath tests tend to be fairly unreliable. So we see people who have got IBS type symptoms getting the same results as people who do not have IBS type symptoms, which makes us already think what's going on here. And the other thing we see with this is that the same person can get different results when they're doing the breath test on different days. So we would never use a breath test in isolation to diagnose someone with something. We would be looking at that in context of their symptoms and what's going on and what's happening with their dietary management. The aspirate, that's a lot more tricky. That involves usually quite heavy sedation. It involves a gastroscopy, so a camera down the throat, into the stomach, into the small intestine, and then taking a sample of the fluid that's in the small intestine and looking at that under the microscope. Obviously, that's a lot more invasive and does carry some risks as well. So we want to be, if we're diagnosing SIBO in that way, we want to be fairly sure that this is what's going on. A lot of doctors will not often use this because the treatment for SIBO is antibiotics, and a course of antibiotics actually carries less risk than the gastroscopy to diagnose it. So sometimes there's a bit of a way up there over what's the best way to manage this when SIBO is suspected. The types of symptoms we see with SIBO, we see altered bowel movements, so constipation, diarrhea, pain, bloating, and that bloating often occurs fairly soon after a meal, in particular in relation to foods that are fairly high in starches and sugars. Some of the other things that we see in SIBO is sometimes we'll see low iron levels or low B12 levels because that bacteria may be interfering with absorption of certain nutrients. Some of the risk factors that put people more susceptible to SIBO are things like motility disorders, so constipation or gastroparesis, which is that delayed stomach emptying, use of proton pump inhibitors, which are used to neutralize stomach acid and help with reflux, so that neutralizing of the stomach acid can put you at a higher risk for SIBO. If somebody has had abdominal surgery, or if they've got something anatomical going on like bowel obstructions or adhesions or celiac disease, those sorts of things going on, they can increase the risks of SIBO as well. As I said, treatment for SIBO is usually antibiotics, so we're looking at rifaximin, neomycin, ciprofloxacin, flagyl, and metronidazole. The thing with SIBO is that it has a fairly high recurrence, so we're looking at treating SIBO with an antibiotic, and then after that, working out, okay, what are the things that are putting you at higher risk of SIBO, and what can we do to prevent that recurring? In terms of diet, we're really limited with research. We don't have research. Obviously, we know that the FODMAP diet can help with symptoms, but we'll see talk about things like a biphasic diet, a fast-track diet, or a SIBO-specific diet. There's really no research for any of these diets. I don't use them because they tend to be fairly over-restrictive and they increase those risks of nutrient deficiencies and things that we're already seeing in people who've got SIBO. So they make a bad situation worse sometimes. There is some talk of herbal antibiotics, and there was one study that looked at a comparison between rifaximin and herbal antibiotics. Now, this actually wasn't a particularly good study, and it concluded by saying that the herbal antibiotics are as effective. But when you actually go back and read the study, you can see that the rifaximin wasn't used at therapeutic doses. The diagnosis was not done accurately, and it was actually what we call a retrospective study, where all they did is they went into a place and they pulled up records and they read the records. So they didn't trial, there was no actual trial involved, it wasn't randomized, and it wasn't well controlled. So herbal antibiotics are not something that is well evidenced for treating SIBO. If you head down the naturopathic route, it's likely you'll be offered them, but really there's no evidence to support them as good or as effective for managing SIBO. Which brings me to bile acid diarrhea. Bile acid diarrhea is when there is an excess of bile acid in the colon, and this is the result of malabsorption of bile salts. So you've got underneath your liver, there's a little organ called a bile duct that stores bile acid. And when you're eating food and it passes through your stomach and into the small intestine, the bile duct releases small amounts of bile salts into the intestines at the same time. The bile salts travel through the intestines at the same time as the food. As they're traveling through, they break down the fats. And then at the end of the small intestine, the bile salts and the fats are then absorbed back into the body. Now, if that absorption at the very end of the small intestine is not working properly, it may be that there are more bile salts in the intestines than what is needed. It may be related to some sort of damage in the small intestine, or it may be that somebody's had surgery and had that part of the intestines removed. We then might see things like bile acid diarrhea. So those bile salts then pass into the large intestine. We see loose, watery diarrhea. It's usually fairly urgent. We see bloating, and sometimes the stools can be sort of a yellow, pale brown, or grey colour. In terms of diagnosis, there are a few tests that we can be doing, so stool samples and things, but these aren't really have limited availability. And the most common thing we see is that someone will look at those clinical symptoms, will look at that history, and will say, let's trial you on what we call a bile acid sequestrant, which might be something like cholestyramine. And what that does is it binds those bile acids so they don't cause those loose, watery bowel movements. Sometimes, if it's not too severe, we can manage bile acid diarrhea with a low-fat diet, but that's a little bit of a balance, and it depends on the severity of your symptoms and the severity of the malabsorption. So the gut-brain axis is a really integral part of irritable bowel syndrome, and I really did want to touch on this as part of this. So the way I understand this is it's when I compare it, I'm thinking we've all got our five senses, so our touch, smell, taste, sight, and those senses collect information from what's going on in your outside, around you, in your outside world, and it delivers that information to the brain. The brain then looks at that information and it weighs it up against past experiences, your current situation, and future expectations. And the brain will then decide if this is a situation that is potentially dangerous, that it needs to be worried about. And if it interprets the situation as dangerous, the brain will then send a pain message to get your attention and get you to change what's happening to protect yourself. So pain is essentially quite a complex protective mechanism. So a nice little example of this is if you put your finger on a hot element, your finger collects the heat information, it sends that information to the brain. The brain says, oh, wow, that's super hot, that could potentially burn us. So the brain sends back messages of pain in that finger to get you to move your finger away from the element and protect yourself from getting burnt. When we're talking about the gut-brain axis, so the enteric nervous system, or your gut brain, that's designed to collect information from what's going on inside your body. So it's collecting all that information about digestion and what's happening and what's going on, how fast things are going, how slow things are going. And it's collecting all that information, and it is sending it up that gut-brain axis, or the vagus nerve, to the head brain, so the head brain can interpret it and decide what's going on and what it needs to do, or if it needs to do anything at all. And when we're talking about IBS, what happens is those nerve endings in and around that gut tend to be hypersensitive. So they collect a lot more information about digestion than somebody who doesn't have IBS. So we might have the exact same thing going on in two people, but one person's nerve endings are collecting a lot more information about digestion than the other person. And the person who's got those sensitive nerve endings are over communicating and overloading the brain on information. And the brain is then getting quite concerned about that information. So it's sending back those messages of things like pain and bloating, or it might be speeding up and slowing down the bowels to get things to change, to make your situation a lot more comfortable. And this is where the gut-brain axis plays a critical role in those IBS type symptoms. Interestingly, when we're looking at the gut-brain axis, gut-directed hypnotherapy has shown to be quite beneficial. So this was first put on the radar back in the 1980s with a psychiatrist called Professor Worrell, who had a whole lot of people who had IBS symptoms who weren't getting results with traditional treatments. And he gave a group of them gut hypnotherapy, and a group of them just had talk therapy and placebo medications. And he found the people who had the gut hypnotherapy got a much better result than the people who had talk therapy and medication. So that was when we first started thinking that maybe there is something in this. Then back in 2016, Dr. Simone Peters at Monash University did some research into gut hypnotherapy as well, where we looked at, actually at 74 people, a third of them had gut-directed hypnotherapy, a third of them did a low FODMAP diet, and a third of them did a combination of both a low FODMAP diet and the gut hypnotherapy. These people were assessed at the beginning for the severity of their gastrointestinal symptoms, their quality of life, and their anxiety and depression scores. And we assessed them at the beginning, at 6 weeks, and at 6 months. And interestingly, at the 6-week mark, all three groups had had an equal improvement in their IBS type symptoms. And that it was an equal improvement, so we could actually get that improvement with gut hypnotherapy alone, and you didn't have to change your diet at all to get that improvement. That result was maintained at the 6-month mark, but where it gets really interesting is that the people who had gut hypnotherapy were doing slightly better, and particularly in the area of anxiety and depression, than the people who were doing the FODMAP diet as well. So that started to get really interesting for us. Which now brings me back to Lisa. So you remember Lisa? I saw her back in 2018. Lisa was fit and healthy. She was getting eczema, which she thought was food related. She had some mild stress, and she was using Headspace app on most days to manage that. She had a supportive husband and 2 grown children who are looking after themselves. She really enjoys shopping and cooking. She works part-time, and she previously tried a low FODMAP diet and a gluten-free diet to manage her chronic constipation, bloating, and burning in the digestive tract. So some of the things that I noted when I saw Lisa is that, first of all, there were no red flags. She hadn't had any unexplained weight loss. She hadn't had any rectal bleeding or anything like that. And in fact, she had actually seen her gastroenterologist and her GP, and she'd been tested for all of these things and been given a clean bill of health. Her symptom profile included gut symptoms, skin symptoms, and central nervous symptoms. So she was getting fatigue and lethargy as well. Her previous interventions that she tried was low FODMAP and gluten-free, which had given her some improvement. When we looked at her food diary, she wasn't eating any FODMAPs at all at this point. She was completely gluten-free. She was eating a lot of food chemicals, but her diet was actually fairly limited, where she was eating the same foods day in and day out, and she was not getting a lot of variety there, and she was not meeting her nutrient requirements in a lot of areas. The foods that she had identified that triggered her symptoms were the FODMAPs, of course, because they were on her radar. There were definitely food chemicals, so low FODMAP foods that were high in food chemicals that she'd identified that triggered her, things like chocolate and aged meats and aged cheeses. She also found that starchy foods like potatoes and rice, and they were often triggering symptoms fairly soon after eating. She did have some risk factors for SIBO, in that the constipation was there, and she was, like I said, getting that bloating fairly soon after eating and with those starchy meals. So what we decided to do with Lisa is that we started initially, we thought, let's treat her constipation, because if that backup of stool in her large intestine is contributing to her symptoms, that's something that we could address fairly quickly. So we thought we'd start by doing that. So we put her on 2 kiwi fruit a day. Kiwi fruit are magical for constipation. They're amazing. We decided to increase her fibre as well. So I popped her onto a fibre supplement called K Fibre that I find particularly useful for treating constipation. And we introduced some oats into her diet and made sure that she was getting enough fluid. Because of that early bloating, we decided to treat her for SIBO as well. So we saw her doctor and we put her on rifaximin. And one of the things that we know about rifaximin is that it seems to work better and be more effective if somebody is eating a high FODMAP diet at the same time as they're taking the rifaximin. So it seems that when the gut bacteria are well fed, they're more alert and they're more responsive to those antibiotics. So what I recommended she introduce with those antibiotics were some of these low chemical high FODMAP foods, things like garlic and apples and cashews and legumes, which yes, they're high FODMAP, but they're all low in food chemicals. So I was hoping if she was food chemical sensitive and not FODMAP sensitive, she would actually tolerate some of these foods quite well. At this stage, I also provided Lisa with some written information. I was quite suspect of the food chemicals, so I gave her some written information about those food chemical sensitivities to read over in the meantime before our next appointment. So at our next appointment, I was really excited to hear that Lisa had actually felt really good while she was doing that SIBO treatment. So while she was eating those high FODMAP foods and taking the rifaximin, was the best that she had felt in a long, long time. She had introduced garlic, apples, and cashew nuts into her diet at that point, and her symptoms hadn't increased, so she was still actually eating them. So we'd already expanded her diet a little bit. Her bloating had decreased significantly, but she was still getting constipation, she was still getting rashes, and she was starting to notice some sinusy type symptoms as well, which I thought was interesting. She had read through the information on the food chemical diet from Royal Prince Alfred Hospital, and she said that that set off a lot of light bulb moments for her, and this was something that she actually really wanted to trial. So I educated her on the low chemical diet. We got her a bit of a meal plan about what she could eat during that stage. We kept those FODMAPs in because she was tolerating them really well. And when she came back to me after that elimination, she said that she had had a significant and consistent improvement the whole time she was on that low chemical diet. So we knew we were on the right path with this, and we started challenging and that reintroduction process where we were bringing things back in a very structured way. And what that identified for us is that Lisa actually, when she tolerated the salicylates really, really well, but the amines turned out to be quite a big trigger for her. So we started expanding her diet where we bought all the salicylates, we brought wheat back in, we were able to bring back a whole heap of FODMAPs and really just limit those amine foods initially. We also thought, okay, we do want to prevent this constipation recurring. Now, limiting the amines actually made quite a big difference to the constipation, and she was finding that she really wasn't struggling anymore as long as she wasn't eating a lot of amines in her diet. But she did keep taking the K fibre and she did keep eating the kiwi fruit to help manage that. And we figured that would stop that SIBO reoccurring in her. And I did manage to see Lisa again about a year later. And this was more of just a bit of a touch base, because when she came to see me, she was saying she had no abdominal symptoms at all. So there was no burning, there was no constipation. Her skin had settled down and she was feeling really comfortable digestively in her skin and everything. Sinuses, there were no issues going on there. At this point, when we looked at her diet was actually really wide and varied. She was meeting all her requirements in terms of getting those macro and micronutrients in, which was brilliant. She was avoiding amines a lot of the time, but it was really only the foods that were super, super high in amines that she was being quite careful with. And because she was doing this the majority of the time with these foods that are super high aiming, she found that on those occasions where she was out to dinner with friends, or if she was just really wanting to eat some chocolate or something like that, she found that if she threw in those super high foods occasionally, she was actually getting away with them quite well. On the odd occasion where she knowingly ate a few more than what she knew she could tolerate, she was quite careful and structured about how she did this, and she would always work it out so that those days she would always allow herself a day for recovery the next day, where she would have a quiet day, she would take care of herself, get some light exercise, a hot pack for that tummy from the bloating, and she would make sure that she was up to date with her fibre supplement and her kiwi fruit so that she didn't get constipated from those situations. In terms of her gut health, Lisa had no concerns at that point at all. She was feeling overall fit and healthy and energetic. The best part for me, which made me really happy, is that she came to me saying, I love food again. I'm excited by food again. I'm excited to be eating out with friends and trialing new foods and all of that all over again. So Lisa was a really great outcome, and we really enjoyed working together. So finally, if you're looking to connect with me, you can find me in a few different places. So on the internet, my website is www.everydaynutrition.com.au. You'll find a lot of information about myself and my team of dietitians on that website, and also there's a lot of recipes and blogs and articles there with more information about FODMAPs and food chemicals and other types of things that can cause gut symptoms. You'll find me on Facebook, so Everyday Nutrition is my business page on Facebook. I also run a group called Low FODMAP Australia, and you'll find me on Instagram at The Gut Health Dietitian. So send me a message, tell me what's going on with you. I'd love to connect with you and get to know you. Have a great afternoon. Bye.